We know that vitamin D helps to prime the T cell aspect of our immune system, which is considered to be important in the body's response to the presence of the virus. So I think it's important that maybe something that others could also decide to do, screen all COVID patients for vitamin D deficiency and see if you also pick up this occurrence that I've observed, which is that the more deficient they are, the more likely they are to have severe COVID.
Welcome to the FLCCC Weekly Update. I'm Betsy Ashton. I'm the creative director of this association, and we're here once a week for 30 to 45 minutes, sometimes an hour. We might go long tonight because we have special guests, and we're here to tell you what works in the prevention and treatment of COVID. Now, in just a moment, you're going to have Dr. Eric Osgood of our team with 4 very special guests, all doctors, and they're going to be talking about help for you long haulers, for folks in hospitals, how to get ivermectin if your doctor won't prescribe it, and they're going to answer your questions, as many as we can get in the time that we have. But first, I have to give you this disclaimer. Remember that we are not giving you personal medical advice. We're not inside your body. We don't know what's going on. Take our information to your personal physician and discuss it. And with him or with her, you decide what's best for you, for your case. Also, I have to give you a little bit of housekeeping, and that is, this is a live webinar. If you want to ask a question of our doctors, put it in the Q&A. That's down at the bottom, not the chat. I mean, you can talk with each other. We love you to tell us where you're from on chat, but it has to be in the Q&A in order for us to answer the question. And know that this is being recorded. You'll be able to see it later if you're unable to watch for the whole hour now. Also important to tell you, who are we? We are a 501c3 nonprofit organization. We do not make any money off of anything we're talking about. We do not sell drugs. We do not manufacture drugs. We have no interest in ivermectin or anything else. We simply want to save lives in this pandemic. And some of you know that we live on donations, and we thank you for supporting this effort. And that's all I need to say right now. Dr. Osgood, are you there with all of our guests? Take it away.
Here we are. Thank you. Thank you for the info. Everybody can hear me okay?
We can.
All right. I'm very honored to once again be filling in for the mighty Dr. Pierre Corey. He has given the reins over to me for this week, and this is a really exciting episode because we have a panel of great doctors who are out there doing great work and taking care of patients in all phases of this disease, and they've been kind enough to take a moment from their busy, demanding schedules to answer some questions, talk a little bit about what they're doing, and to hopefully have a little discussion. We want to make sure we leave enough time for questions and do our best to answer the questions that audience members have. We really appreciate you being here. I just want to say one quick opening thing before we launch into it and start to introduce our panelists for tonight. As moved and as appreciative and happy as I am about these judges ruling correctly to stand up for the autonomy of patients and their families, it really saddens me, and it frankly hurts me to see doctors not doing that. Respect for autonomy is one of the core tenets of medical ethics. We think about beneficence and maleficence and justice. Respect for autonomy. I'm a career hospitalist. I take care of patients in the hospital. I'm a practicing hospital medicine and a teaching hospital medicine doctor. We in the hospital have a special solemn duty to protect and respect autonomy because we're not in the office, meaning if a patient's not happy with what we're doing, they can't just take their business elsewhere. They're stuck there. They might be either on ventilation or high flow oxygen. It's not so simple. And so if the patient and the family and the doctor don't necessarily see eye to eye and the treatment is safe and there's not a compelling reason then we should really respect the autonomy of the patient and the family, because that's one of our core tenets of ethics. And especially with a drug that, I mean, we've heard Dr. Corey talk about how this is one of the safest medicines. Just to give a quick idea, according to the database from the World Health Organization, that's tracked 3 billion doses of this medicine that's been given since 1992. You would have to give more than 600,000 patients this medicine on average for one person to have a serious side effect from it. It is a highly safe medicine. It has been used in mass drug administrations distributed widely through healthy populations, including small children, to prevent diseases. So the notion that they would withhold this medicine just to dig their heels in is really hurtful to me. And I really hope that doctors engaged in this kind of thing in the hospital will see the light. And rather than sort of take our ire and our anger out on these doctors, I'm a little bit more directing of my anger at the system that is creating a situation where doctors fear for their medical licenses just because they're trying to help their patients. And I really hope that we can tackle this and find our way again, because this is just sad. And I really wish that patient and their family the best. All right. Anyway, with that said, let's talk to our panelists. So we have Dr. Miguel Antonados, who has a busy, very, very busy telemedicine practice where he is prescribing early outpatient therapy, exposure prophylaxis, meaning protection for people who don't want to get sick when they're having trouble finding physicians, or their own personal physician will not prescribe it. He is treating many, many, many patients, and he's going to talk to us about his experiences. Then we have a rock star medical resident by the name of Dr. Stephen Hamilton, who happens to train at the hospital where I practice and teach. He has been neck deep, I should say, in COVID-19. He comes from a rock star medical residency program, so he's a rock star among rock stars. And he has been using Math Plus protocols on the medical wards and in the ICU, and he's going to talk to us briefly about his experiences. And then we are so lucky to have Dr. Yo with us, who some people might recognize. He has a show on YouTube. He and his partner, Dr. Bruce Patterson, are doing incredible cutting edge work in precision medicine in dealing with COVID long haul, which so many patients are having trouble finding physicians who know what to do for them. They're basically told, just go to therapy and do yoga, which nothing's wrong with those things, but there are actually medicinal things that can be done for these patients. And the work that Dr. Yo is doing in this field is just absolutely incredible. I'll let him tell you more about that. So we'll get a couple of minutes from each doctor, and then we hopefully will move on to the audience and take some questions, and hopefully that we can adequately answer them. So why don't we start with Dr. Antonados? You want to just tell us a little bit about yourself and what you've been doing? And just to briefly mention, FLCCC protocols were recently updated. We have iMask Plus, which now we increase the protection, what we call pre-exposure prophylaxis, to once a week after you've taken the first 2 doses. And for the early outpatient, meaning you're sick, we added Fluvoxamine and added nasal sanitation to that. And then as far as the Math Plus in the hospital, we made a couple of changes. We increased the dose of ivermectin, and we added some other medicines, namely an old allergy medicine called cyproheptadine, and some other additions to that as well. And of course, Fluvoxamine in both those cases, which is showing some important data, really showing some benefits. And then a couple other medicines as well. And then there is an iRecover protocol, which is still a work in progress, going to be coming out for long haul. And that's kind of how we intersected with Dr. Yo, because some of the medicines he's having success with actually cross over with what we're doing. And so anyway, so Dr. Antonados, go ahead, take it away.
Hello, thank you so much. First of all, I want to thank you, Betsy. Thank you, Dr. Osgood, for having me here tonight. This is a very honor to be part of the panelists in the FLCCC weekly update. My name, Dr. Antonados. I'm an internal medicine physician and owner of telemedicine company Text2MD. I'm, as well as Dr. Osgood, I've been a hospital medicine physician as a career, and have been transitioning to telemedicine for the last 2 years. Since then, I started implementing my service telemedicine to help mostly patients during the pandemic. Initially was mostly providing service for patients that didn't not able to see their PCP due to these shutdowns and helping with the medication refills. At the same time, I was looking at how to help patients further with COVID-19 and trying to read about any emerging medications that we could probably utilize treating these patients and trying to get them definitely out of the hospital. As me working as a hospital as well during the pandemic and at the same time doing telemedicine, I have been able to be in both fronts. Definitely have been using medication in the hospital, and as I've seen patients in the middle of the pandemic, there has been this wave that hospital capacity has been maxing, and I was trying to find a way to help those patients out of the hospital, trying to minimize their hospital stay, and at the same time trying to figure out a way for patients to don't actually end up in the hospital. Patient on stay and in the hospital, they have a mortality rate of about 20%. So this is something that definitely will cut off dramatically the mortality, trying to find an alternative treatment in the outpatient setting. Then I look at the data, mostly about ivermectin data. All the research was going since last year. I introduced the ivermectin after seeing the video from Dr. Corey, the testimony in the Senate. I have a big interest about implementing ivermectin into my practice and treating the patients for prophylaxis, post-exposure prophylaxis, and also for earlier patient treatment. Since December, I introduced the ivermectin for patients that were positive for COVID or suspected COVID. And as well, I was treating patients for the post-exposure prophylaxis on the patients that are high risk. I was treating them with ivermectin for the long-term prophylaxis. So since December till the date, has been successfully treating approximately about 4,000 patients with ivermectin, and has been greatly efficacious, I would say, based on the percentage of patients I've seen. 14% of these patients report no medical problems. So pretty much patients in my practice has at least one or two medical comorbidities, which some of them have the high-risk comorbidities, hypertension, obesity, diabetes. And since those patients are definitely high risk to end up in the hospital and increase their mortality, those are the patients that definitely will were having a great benefit with the earlier patient treatment, implementing the IMAS protocol. As far as the hospitalization rate so far in my practice, it has been very surprising, the numbers actually, based on the data research and my data, I'm still compiling data, has been a hospitalization rate with ivermectin has been around, I would say, probably 1%, a little bit above the 1%. And this is talking about approximately 76% of those patients are high risk to end up in the hospital with severe COVID pneumonia. So this has been very surprising for me initially when I start treating patients, and I follow every patient that I treat with ivermectin. I do a follow-up next day, and I continue follow-up next week. And most of the time, those patients, they get better after 2 or 3 dosage, and they don't require further ivermectin. Some of them, if they come with a little late, I would say late presentation, 5 to about 5 days to 10 days, they may require a little longer from the 5 days of treatment. Some of those patients require additional days, up to 10 days. I have been treating patients and they get better with the COVID. Most of them, as I mentioned, most of them get better. Some of them have lingering symptoms, which I continue ivermectin after having these symptoms, and they definitely they come with me, and so it's a very dramatic improvement. I'm as well native from Panama, and I have been advocating the ivermectin in my own native country, and there has been a very high spike of cases in Panama back in December. That's where I started advocating about ivermectin, mostly in social medias. And I try to get journalists to help me out, bring out the voice in Panama. Fortunately, the government started using the ivermectin back in, started approaching more ivermectin back in March. And we have been seeing definitely a decrease of cases in Panama to the point that all the shutdown has been, actually, this has been, Panama has been, just to mention, Panama has been very strict with the shutdowns. They have this curfew for months. People couldn't go out the street, do nothing.
Sorry, Dr. Antoniatos.
Yes.
So I just want to make sure we have enough time for questions and everything like that. So maybe in the questions we'll get to talk a little bit more about what's going on in Panama. I'm sorry.
Yeah, absolutely.
And just very quickly, you're treating patients in all 50 states? Or in certain
currently I'm treating patients in 26 states. However, I'm working with the state boards to have the practice in different states. For example, I'm waiting still for New York. I'm waiting for Texas and California. So those are states that will be coming next. And definitely the point is, and the goal is to expand nationwide and help as many patients as possible.
We really appreciate everything that you're doing, and thank you so much. So, all right, so Dr. Stephen Hamilton, as I said, Dr. Hamilton has been really doing a tremendous job, as have the other residents in our program. And the residents have been really the unsung heroes of this pandemic because they do so much direct patient care. We really couldn't have done what we did without them in our teaching hospital. And yeah, Dr. Hamilton's really been phenomenal. And I know my patients are in good hands when he's there in the ICU and in the wards. So I want you to tell us a little bit, Dr. Hamilton, about your experiences with the Math Plus protocols and how you feel patients have been doing once those have been implemented.
Thank you, Dr. Osgood. Hi, everyone. My name is Dr. Stephen Hamilton. I'm originally from Kingston, Jamaica. That's where I went to medical school, proud graduate of the University of the West Indies, and then I came here to Dr. Osgood's alma mater, which is where I'm stationed now. I'm one of the upcoming chief residents for the upcoming academic year at our Jersey Shore University Medical Center St. Francis program. My perspective on the COVID experience is unique in that when COVID first started here, I was actually assigned to the intensive care unit. And I saw that dramatic mortality rate and increased severity amongst patients. And I've sort of been able to watch it over this timeline as recently as last week when I was back in the intensive care unit. And personally for me, I actually have an aunt who succumbed to COVID. So it's very dear to me, and the management of this disease is very important, and I'm a strong proponent of using what we have. And I think we have really good medications that have proven themselves. On the floors and in our intensive care units, we've been using the MATH protocol that was introduced to me by my attending, Dr. Osgood, and I found it to be extremely useful. When COVID first started, we used systemic steroids. This is the dexamethasone, the solomedrol, that's a methylprednisolone. And I believe that this strongly changed disease.
I think we lost your audio.
Your audio.
Sorry about that.
Here we go.
And our death rates at our institution. Something that we've been piloting as well, some of the residents, is that we've actually gone for high dose steroids early on. Besides the typical 6 milligrams of Decadron upfront, I personally load most people with 80 milligrams of methylprednisolone, which is equivalent to about 15 milligrams of Decadron. So you can see that we're going at least 2.5 times the typical dose. And I have found that these patients are less likely to become dependent on non-invasive ventilation support, whether it's BiPAP or high flow. And they're definitely less likely to end up being intubated and sedated in our intensive care unit, where the outcomes are just not good. So that's something that I promote. And most recently, I used it on one of our intensive care unit patients who I inherited. She was on Decadron for about 5 to 6 days, spoke to the relatives, got the approval to use that kind of high dose of systemic steroids, methylprednisolone. Not only did she clinically improve, but her radiological features improved. Her X-ray got dramatically better in a few days. I was able to take her from 100% of BiPAP all the way down to about 50%. So that's a 50% reduction in oxygen requirements by simply intensifying the amount of systemic steroids that I was giving this patient. We also use ivermectin. I can speak to the inpatient use, both on the floors and in the intensive care unit. On our general medical floor, we do use ivermectin somewhere around 0.2 to 0.3 per kilogram. And I've personally seen that using this early on, so the patient comes in, they're not fully oxygen dependent, their CRP, their D-dimer are not sky high. That's the ideal person to get this ivermectin on very early, hit them hard and fast. And typically, even before that 5-day mark, we can discharge these people, or they avoid this whole oxygen dependent sequelae in hospital. In the intensive care unit, I've found that at the time of admission to the ICU is the ideal time to get this ivermectin on. Not when the cytokine storm is fully raging, they've been oxygen dependent, ventilator dependent for a few days. That's perhaps not the best time. So I think timing with ivermectin is very important in the intubated and sedated patient in the ICU. And I've seen it work in those who come early on to the ICU. The patient may have very high requirements. We think they need to be watched. We give them the ivermectin and it works. Even if they're intubated on the day of admission, you can give ivermectin through an orogastric tube, and it's just as efficacious. So Great. In terms of systemic steroids and ivermectin, I think it works. In terms of anticoagulation, I think this is something that was overlooked and became a bit too controversial at a point. But in our hospital, we initially anticoagulated everybody, therapeutic anticoagulation, whether it be low molecular weight heparin or unfractionated heparin drip. And I saw a distinct difference between the number of patients who were returning to our hospital. I remember in the beginning, before we were doing this, some people who were treated for COVID went home and came back with massive pulmonary embolism or DVT.
When you say pulmonary embolism, just so the audience understands, that means big blood clots, right?
Massive blood clots in the lung or the equivalent in the legs. And what I found is that when we started adopting this principle of not only anticoagulating them with the blood thinner in hospital, but sending them home on the oral medications for about 2 to 4 weeks, that number dramatically decreased. So I found that this Math Plus protocol works phenomenally. It has not, proven me incorrect. So far, patients do well. Patients' relatives speak of this outcome. And I think that it's something that we should continue to push, not only in the United States, but across the globe. Access to this is very important, and I see no reason to divert from a really good working formula.
Thank you so much, Dr. Hamilton. All right, now we're going to go to Dr. Yogendra, and he is going to talk to us about what he is doing in COVID long haul or long COVID. These are patients who don't even necessarily get so sick that they ever have to go to the hospital. Some do, and they just spend months and months and months, sometimes in misery, everything from brain fog, depression, chest palpitations, chest pain, shortness of breath, fatigue. They go to doctor after doctor, test after test, nothing shows up. They're told nothing's wrong with them. They continue to have a lower quality of life. and through his cutting edge research and medical practice, he's really been turning people's lives around and just doing amazing work. So take it away, Dr. Yo.
Dr. Osgood, yeah, thanks a lot. And thank you, Betsy, and everyone else at the FLCCC. I just got to say, before I just jump in talking about the COVID long haulers, that I think one of the things I learned from going through this whole pandemic and for the past year is doctors haven't talked to each other. This is so powerful. Being able to talk to you guys, talk to Dr. Hamilton, who's a resident. I mean, that's just amazing. You're getting this experience and this exposure, and the sort of having Dr. Osgood as you're attending. These are important to have these discussions, to share this information. Journalists and the media should not be arbitrators of medical advice. It should be us. We're on the front lines. We should be the ones talking about whether it's right or wrong or whatever. We should have these scientific discussions. And we have to take back our medical field. And that's the one thing I've learned from this. And I appreciate you guys, everything you guys are doing, and for having me on today. I wanted to sort of, obviously talk about long haulers and just sort of my background. I'm a board certified anesthesiologist. I sort of have a unique perspective where I run an outpatient wellness center. And so I've seen COVID patients through my outpatient wellness center in Rhode Island. I also have seen patients in the ICU. I see patients in the operating room. And over the past 9 months, really the research and focus of Dr. Bruce Patterson, who was former professor of virology at Stanford University and now the CEO of IntelDX. We've been studying long haulers. We've been studying it in such a way that we have studied over close to 3,000 patients right now, and we put out a publication. We have a couple more in the pipeline that is coming up. The point is that, and I know we're going to talk a little about long COVID, but just in COVID and really any disease in general, our bodies are always telegraphing a message. And our jobs as clinicians are to pick up those signals and translate them into clinically actionable plans to make lives better. All of us are clinicians here. We're not researchers. We're not writing papers and patting ourselves on the back and getting tenured in a nice big cush office. We're all here to take care of people. And the goal of research is to take what we're seeing in the lab and what we're seeing in the microscope, in the flow cytometry, and figure out ways to create plans, actionable plans today. That might be an experimental drug that's 5-10 years away. I don't really care. I don't think you care, Dr. Osgood. I don't think you care, Dr. Hamilton. We want to find tools in our toolbox today. And obviously one of those tools is ivermectin. I've got experience using it outpatient. I've seen it work in the ICU. I've had my friends of mine that have used it. So definitely, it's one of the most powerful tools we have in the toolbox. But in terms of long COVID, what is long COVID? I mean, in the summer of last year, we started looking into these group of patients. The focus has been on the pandemic. The focus has been, and rightfully so, on the acute phases of the infection. It's a pandemic. It's killed millions of people, or affected millions of people. I think getting close to over 2 million people that have succumbed to the disease. And once we started hearing about these people, these long haulers, they're having symptoms. And usually whenever we have any viral infection, we know, listen, there's going to be some fatigue, there's going to be some respiratory issues for a couple of weeks. But these are patients that were having persistent symptoms 3, 4, 5 months. This is what we started looking at last summer. Now we're at a point that it's 14, 15 months afterwards, and these people have debilitating illnesses. They're on disability, they're out of the workforce. Moms cannot pick up their kids. Dads can't go to soccer practice with their kids. Grandparents can't pick up their grandchildren. Doctors can't go to work. Big business people who build multi-million-dollar factories and businesses are out of the workforce. And for us, that was really telling when our colleagues, when friends of mine were, and really I got into this because one of my friends I did residency with, another anesthesiologist in Missouri, he said he quit his job because of long COVID. And we looked at his blood. And it was very interesting. I said that our role as physicians is to pick up those signals and those messages our body's telegraphing. And we started looking at these immunoregulatory proteins called cytokines. And I think Dr. Hamilton sort of touched upon the cytokine storm. And we see that, and what they are messenger proteins and how the immune system is really communicating with each other. And we found that there was hyperinflammation taking place months after infection. It's almost like there's fire all over your body. But see, the problem in clinical medicine is we think of fire, we think of steroids. We say infection, we think antibiotics, and we put you on a Z-Pak. We have back pain, we say we're going to put you on gabapentin. We treat symptoms, we don't treat the disease. So we found the fire, but the question was, and this is something in clinical training and as physicians sometimes we miss, is we don't ask the question, what is causing the fire? And we started looking in a little bit deeper. We discovered, and we put this paper out at the end of December, where we found what's called the immune signature. A simple way of really describing it is the fingerprint of long COVID. It was a statistical model using artificial intelligence with a 97% sensitivity and 100% specificity, what we call the long hauler index, which is that fingerprint, where we could now classify someone using artificial intelligence and this algorithm we had developed, classifying them as a long hauler based on this score. And the score is anyone that had a score of 0.75 or greater was considered a long hauler. And that was based on these elevated cytokines and the pattern. If you had the fingerprint, we would then able to call you a long hauler. And it's important for a couple of things, because one, we now have a diagnostic tool to measure response to therapy. I mean, when patients come in and they say, I have brain fog and I have fatigue, what does that mean? There's no test for that. There's no imaging test for that. There's no blood work for that. So they go to the office, to that doctor's office or the hospital, these long hauler clinics. They get these routine blood work, they get routine imaging, and there's nothing wrong. And they're told there's something wrong in your head. And they're kicked out of the clinic. They're given a benzodiazepine or asked to go see a therapist or a psychiatrist because there's something wrong with you in your head. But no one's ever asked the question and really dug a little bit deeper. And that's what Dr. Patterson and I have done. And Dr. Patterson's lab, InCellDX, really started digging and using the cytokine assays, and we found that signature. But here's the question. It didn't answer, where's the fire coming from? The first paper described the fire. The first paper described the fingerprint. It's now peer-reviewed and accepted and should be out in the journals in about 2 weeks. The preprint is available on our website, covidlonghaulers.com. But most recently, about a month ago, we started finding COVID proteins in a subset of macrophages in the long haulers. What does that mean? That means that there are viral particles persisting in those immune cells. They're like the garbage trucks of the body, and they're going all over. The full pathogenesis, Dr. Patterson's next manuscript is going to be laying out the full pathogenesis of long haulers. And our treatment is what we're doing is precision medicine, where we're measuring the cytokines on these patients and we're targeting specific therapies. There's no one drug. I think that's the one thing I've also learned from COVID is there are no one drug that's going to resolve COVID or really any of these issues, but it's combinations and it's understanding the patterns and knowing where you are in the disease. Combinations, we are using ivermectin. We use a Fluvoxamine. We're using another drug, an HIV medication, it's a CCR5 inhibitor called Maravirac, along with a couple of other medications. So everyone gets a different medications, a different protocol based on what their immunology is showing. And here's the really exciting thing. We've got about over 3,000 patients in our database. We've started treating about several hundred patients already. In about 2 or 3 weeks, a lot of them are getting better. How do we know they're getting better? Because the blood work is now showing it. We have what they were before. We know what they are after, why they're feeling better. And now we're starting to introduce more lab work where we can now go and detect. If you say you feel better and your long hauler index, that algorithm shows you're no longer a long hauler, we can now go into your blood work and see if you still have the COVID proteins. If we can now confirm if we put the fire out, not that at the source of the fire, not just put the fire out, that you're completely recovered, that you're not going to relapse. And that's the really exciting data that's coming out. And we're getting a lot of new research and the patients are saying, look, we're feeling better. And we can now scientifically and medically justify why we're doing what we're doing.
So this is incredible because if you think about the big 10,000 patient randomized controlled trials that everybody's calling for, that's almost like a sledgehammer and you guys are using a scalpel, right? And unfortunately, the sledgehammer cost $5 million and it takes a year to get back. You guys are actually going right in there and using a more of a precision, high precision approach to creating these fingerprints for people, figuring out what's being expressed abnormally, using medicines already at our disposal, FDA approved for different conditions, but have that profile, that ability to attack those things that are abnormal. And then you can track, watch them normalize while you watch the patient get better. And that is your evidence, and you see the patients improving. That's basically what you're doing. Incredible.
Absolutely. Absolutely. And you know what? It's been beaten in our head. You know, the PCR is the gold standard. No, PCR is a terrible test. I mean, I think any clinician that's been out in the front lines and treating COVID patients and done this test, we know there's a lot of false positives, false negatives with the PCR. Another thing that's been beaten in our heads, the randomized control trials, the double-blinded placebo, blah, 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 blah. We hear that since day one of medical school. And it's almost like we become drones and robots that we just start spewing it out. But there are ways that we're scientists at the end of the day. We have an MD or a DO after our name. We're scientists. And we got to critically think. And there's different ways of studying things. You look at mechanisms, understanding mechanisms, how things are working. Why is this drug working? We know why ivermectin is working. We know specifically what cytokines it is decreasing because we looked at hundreds of patients. We know what Baroverac is doing. We know what Luvox is doing. So now when we see these patients and they got these elevations with these symptoms, we can do targeted therapies and we know what their response is going to be and we can measure it. And we've got the evidence to then show it. We're not throwing something against the wall and hoping it sticks.
Amazing. All right, let's get to our questions.
Absolutely. This is very, very exciting. And the first question that I have is for any one of you. It is from Amanda Martin. And the question is, does the prophylactic use of ivermectin reduce asymptomatic transmission? Who wants to handle that one?
So
go ahead, please.
Yeah, I can. So my experience with a prophylaxis dose of ivermectin, I recommend definitely a patient on high risk because you don't want to even have a chance to contract the virus. There is a chance of even patients that are asymptomatic. There is a research study showing that those patients, they may develop a long haul symptoms along the way. So it's around 10%. I remember I reading the study. So definitely I recommend patients to be on the prophylaxis dose if they're in a high risk or a post-exposure prophylaxis per the IMAS protocol. It is very effective. In my own experience, as I mentioned before, I have seen many patients and treat them with a prophylactic dose. And I have 1% of these patients has been reported symptoms after the prophylaxis dose. So it's very, very effective. 99% of these patients, they won't experience any COVID. And they have been they have been tested for getting the PCR test, and they have been negative after the prophylaxis dose. And with household exposure, someone taking care of their family member, and definitely there is a lot of exposure there. And those patients with a prophylaxis dose, they don't develop COVID.
Yeah, and just to follow up on to answer that question about will it actually help you reduce your chances of asymptomatically spreading? We had a study done by Dr. Schwartz in Israel, who runs one of the world's most prestigious tropical medicine and infectious disease centers, who did a double-blinded, randomized, placebo-controlled clinical trial where he demonstrated that the patients who were on ivermectin, they were rendered non-infective. They were 3 times more likely to be non-infective. By non-infective means you're not going to be able to spread it to anybody else. 3 times more likely to be non-infective by day 6. And then that accelerated more and more. It was statistically significant. So that's really the highest form of clinical trial that was done. And he demonstrated factually, essentially with that trial, that, yeah, you can render people non-infective more quickly with ivermectin.
Does that answer, this is another question for Dr. Antonatos from Shari Gilbert, how long it takes to reach a protective level of tissue concentration when you're on a prophylactic dose of ivermectin?
So based on the half-life of the ivermectin, half-life is around 18 to 36 hours. The first dosage may provide prophylaxis for at least the half-life. Repetitive dosage are more effective. It will concentrate more half-lives. So this tissue concentration with ivermectin with repetitive dose, so studies are showing that it can be excreted from the body in around 14 days. So you will have an effect of ivermectin after repeated dosage, after the loading dose, and after the, so you will have definitely protection for the prophylaxis, and then the maintenance will be, if you're at high risk for severe COVID, you should maintain a dosage prophylaxis every week. So yeah, it will last. Even I ask patients, if they're running out that week, I let them know sometimes they have still ivermectin in the system. If they're not taking the prophylactic dose, if they miss a few days, we can get them again the prophylaxis dose, and they should not be major risk. I have seen patients that they're taking the weekly dose. For example, they pick a day of the week, a Monday, and they get exposed, for example, on a Thursday with a COVID positive patient. And what I usually do is I recommend another loading dose the day that they are aware of the exposure, to repeat the same cycle on day one, and then repeat 48 hours and continue the same prophylactic dose weekly. And it has been very effective this way, repeating loading dose every time some patients get exposed.
We have one for Dr. Yo. This is from Linda Banyal. Is there a protocol to help me get my taste and smell back? It's been gone since January 1st.
A great question, and one we get asked a lot about is our protocol, and it really depends because, you know, I said our bodies are always telegraphing a message. Everyone's body is unique. Everyone's immunology is unique. So it's very difficult to say take XYZ medication and it's going to target it. What we do know, though, is that this is becoming very, very clear to us from our research that those garbage trucks or those macrophages are causing endothelial damage. This is causing a vascular irritation. And some of the loss of the taste that patients are experiencing, the brain fog that they're experiencing, we hear that across the board. 79% of patients that have elevated VEGF have brain fog. So we're starting to make the correlation of what cytokines are elevated. And it's very hard for me to say what medications would work and what combinations, because we also have to take into consideration your medical history, what your allergies, what are some of your other conditions. And that's what clinical medicine is about. And this is why I think all of us are, you know, you have to talk to a physician. I will say one of the unique things about what we're doing is we built a network. Just like a lot of the FLCCC doctors are part of our network. I call it network in a sense because we got gaslighted by the medical community. Establishment hospitals, establishment university programs said they want nothing to do with us, even though now we have a peer-reviewed paper. We have the NIH director who is now talking to Dr. Patterson, and he has our paper in his hand, and he's absolutely thrilled. I'll tell you that right now.
That's
to read our paper. And we have 2 meetings with the CDC this week on our research. They had no idea what we were doing. It's been all with just us and the patients. And what I wanted to say is that, you know, we're trying to, if you are not with us, you know, there's a Tupac Shakur line. I know, you know, we're talking medicine here. You either ride with us or you collide with us. And that's the way I look at it, because we are starting this movement right now, and we're trying to find like-minded doctors, and being able to talk to the FLCCC doctors like Dr. Osgood, Dr. Hamill, Dr. Antonados. This is great because this is about a movement here. I know you guys always talk about it, but we started doing this. And when we started showing the science and the medicine and the data, more people started coming. I know I didn't answer Linda's question, but it's precision medicine that we're doing. We are doing the testing on covidlonghaulers.com. All of the science, all of the research is there, but most likely it is due to some sort of endothelial vascular irritation.
Who does she call to get help?
It's all of this, all of our contact information is on the website. You can go read about the science and you register for the testing. And within a week, we can get you all into our program.
Okay, Linda, there you go. We have a question now from Danette Lane for Dr. Hamilton. I've been told that all ivermectin is not equal. Is there any truth in this? And is ivermectin that has been compounded in a specialty pharmacy good enough?
Okay. I think that ivermectin is equal across the board. There's no difference in the effect based on formulation. We've actually not had any concrete evidence to suggest the opposite. I think whether it's in a normal pharmacy, in-hospital pharmacy, specialty pharmacy, the effect of the drug will be the same. The required dose will be the same. There's this notion about normal dosages or supra-physiologic dosages that are required. I don't think there is any merit in considering that there would be a significant difference. I think it's equal across the board.
Okay, that's good to know. Now, this is a question from M.R. Hudgens for Dr. Yo. If you were to get a bad case of the flu, would you take ivermectin for it?
That's a real good question, and one we've been asked. We've been asked a lot. Considering the fact that there is, very little. I haven't seen any really research on the use of ivermectin with the flu. If I got the really bad case of the flu, I would, only because, again, it really depends on how severe my influenza infection was. And that's because of the safety profile. I think Dr. Osgood just mentioned about the WHO, or might have been the CDC talking about the safety of ivermectin. It's been used in humans since 1988 in, I think, over 3 or 4 billion people around the world. So for people to question the safety behind it, it's mind-boggling. I would, and again, only because of the safety behind it, but it's more about how severe my flu would be.
This reminds me of an interview that I did with a doctor in South Africa. And he was talking, he's used ivermectin a great deal, and he talked about the experience of some of the ranchers down there, farmers down there, who early on gave, of course, they all knew about ivermectin because they had it for animals, right? They all gave it to their livestock. And so they also got it, they were taking it for the family, and they had 200 workers on the farm, and they told them what it was and said, if you're interested, what? And they all the people said, yeah, we'll take it. So for a whole year, the whole staff of the farm took ivermectin, and they never got anything. They never had a sick day. He said it was unbelievable that they've never had anything like this. No flu, no colds, no nothing. People who just normally got sick never got anything. What
this
can I say?
Scientific discoveries get made. That's how they figured out the original way we figured out how to vaccinate against smallpox. That's often how it works. Do we have any fluvoxamine questions? Because the addition of fluvoxamine to our protocols is kind of a big deal. I figure if anybody out there has a question about that, maybe that'd be good.
Not yet, but I do have a question for you coming up. Let's see. This is from Sharon Oliensis. Since ivermectin is so effective, is there any need to still get the vaccine? Is there any protection the vaccine provides that I cannot get from ivermectin?
So,
that covers a lot of territory.
Yeah. So, ivermectin is what we call medical prophylaxis. It's a medicine you can take. With the vaccines, what we have is we have these massive clinical trials, and we have a lot of evidence about the kind of antibodies that you form after you get the vaccine, which we know are capable of neutralizing the virus and to essentially prevent person-to-person spread. And so I don't think ivermectin to be sort of at war or at odds with the vaccine. There are massive swaths of the world who do not have access to the vaccine yet. And it is a very good option, a safe option to be used there. People can use it until they are able to get the vaccine in countries where it is available. So I don't necessarily like the idea of putting one up against the other and saying, do I have to do one, do I have to do another? I would say that if I advocate to get the vaccine, but I don't tell people or dictate to people what to do. And if people are not going to get the vaccine, absolutely, there's no way I can convince them. I would say, yes, then take ivermectin. but I'm not going to advocate against getting the vaccine. So that I hope that's a satisfactory.
That's fair enough. And we do have a question on Fluvox, and I'm told this is the last one. And I hope somebody can mute their mic, because there are little children and family in the background that we're hearing that's kind of making it difficult to hear our speaker. I don't know whose family is back there. They sound cute, but it's a little difficult. It's a little hard to hear the rest. Anyway, okay, so here's the question on fluvoxamine that you wanted. Is that if someone is on an SSRI and needs to go on the protocol, should they replace their current SSRI with fluvoxamine?
I would say no, because there is data on a number of SSRIs that is also positive, and that it is protective against the severe inflammatory process of COVID. So it's fluoxetine, which is the generic for Prozac, also some good data behind it. And so there would not really be a good basis to switch to one. I think the differences between them would be minimal, and it would be sort of a disruption to someone's medicine regimen. You wouldn't want to combine them because that could cause problems. So fluvoxamine is the one that's been best studied in the most high quality trials. But if you are on an SSRI, chances are that is giving you some degree of protection. Probably not worth now switching, or adding a second one would not be warranted.
Are there dangers of Fluvox when used in COVID? One more question. Anybody?
Do you want to, or anybody else want to take that one? Or I'm happy if anybody else wants to.
Yeah, you know, with Luvox, we've got quite a lot of experience with it now. I mean, we've been studying Luvox really in depth, and the immunology behind it. It is clearly an immunomodulator working on, on the endothelial dysfunction, or some of the endothelial cytokines, more specifically.
Basically, just so people understand.
Yeah, so basically what's going on is there's some sort of, obviously when there's inflammation, there are these signals the blood vessels are sending saying, look, I'm inflamed. And what Luvox is doing is it suppresses that signal from going out, that the hyperinflammation signal. It's working on the sigma-1 receptor of the endoplasmic reticulum, which is a sort of it's a part of the cell that kind of acts as a gatekeeper, and it's sort of kind of preventing that hyperinflammation from taking place. In terms of the safety, and really it's been around. It's FDA approved for OCD. It's very cheap drug. I think we've got patients paying about $5 to $10 for a 2 or 3 week dose of Luvox. So it's relatively cheap. It's a generic version of it. A lot of data on it. Really, the only thing that would be of a concern, and as you brought up, Dr. Osgood, is another SSRI. There's always a risk of serotonin syndrome. And that's just one that we kind of just try to flush out, and usually start out at a low dose and sort of increase that. My approach with long haulers has been 12.5, and then gradually increases to 25 and to 50, just to see that response to the Luvox. And there are some patients that just don't respond to it. Some have taken high doses and ended up in the emergency room with serotonin syndrome. So again, we have to be very careful. Even though it's highly unlikely that someone might be sensitive or might be on other medications that causes that. So that's, from my experience, that would be the only concern I would have with Luvox.
Well, the question, and others jump in too, do you have any concerns about the length of time anybody takes this and becoming dependent on it?
No, it's a short. Yeah, it's only 10 to 14 days. Right now, the FLCCC protocol is 50 milligrams, 10 to 14 days. To really act as an antidepressant, where it gets your brain and serotonin levels up. People are on it longer than that. So this is a pretty short duration and a dose where you're unlikely to see a high number of severe side effects, probably more side effects than ivermectin. But there really does seem to be very high quality data showing it's very protective against that severe inflammatory state that lands people in the hospital. So it's a risk-benefit analysis. And I think the combination of those drugs is actually going to be a very powerful weapon that we have. They're the only 2 drugs that together trial that it has made it through all the way into the last phase of it. They keep dropping drugs that seem not to be working. Fluvoxamine and ivermectin are the 2 that have been at every single stage so far. Now they're in that possibly last or next stage with now new drugs being added. And so they are really proving to be kind of a dynamic duo in protecting people against this disease.
Anybody, Dr. Atananos or Dr. Hamilton, anything else you want to add to that or thoughts?
So yeah, I have been implemented fluvoxamine with ivermectin for early patient treatment. I started since March, started implementing the protocol, adding the fluvoxamine. The dosage I'm using is the dosage recommended by the FLCCC, the 50 milligrams twice daily for 14 days. And this medication definitely is very helpful for patients with COVID, patients with that may be a high risk of deterioration, patients that are having more than 5 days, even patients less than 5 days of symptoms, they definitely get improvement. Definitely, as I will agree, the downside will be medicine interactions. We cannot use it with a patient taking SSRIs. There's also need to be checked for other interactions with fluvoxamine. And the side effects as well. There is patients, the 50 milligrams twice daily seems to be patients, most of the patients seems to be tolerate very well. But there's a chance some patients may not tolerate the medicines, the 50 milligram BID. So what I do is try to titrate it daily and continue the medication if patient is able to tolerate. And we increase gradually if able to tolerate the 50 milligrams daily for at least for 3 days, and we try to increase it again and see if able to tolerate. But definitely have a very good experience. There have been patients that they come with me with oxygen levels that are quite critical for outpatient treatment. Those patients, sometimes they don't want to go to the hospital. Even I recommended to be checking the ER when they have a low oxygen. They don't want to go to the hospital. I start the protocol with a fluvoxamine, and they start getting better, and their oxygenation improve, and definitely they avoid hospitalization. So it has been very effective as well with implementation of the protocol, have been helping more patients with high risk, and patients are actually in the pulmonary phase, and this has been working well.
Dr.
Great.
Hamilton, have you seen any of this? You're treating patients at a different stage.
Well, here we haven't started using the SSRIs as standard therapy, but if I could make a comment on something that I saw in the chat, someone commented to me about vitamin D deficiency. It's something that I've seen in a lot of the patients, and I've seen the correlation between severe COVID and severe vitamin D deficiency. So something I've been doing for perhaps the past 6 months is every patient that comes here gets a vitamin D level. And I've noticed that most of them have levels below 10, which is considered significant deficiency. And my practice is everybody who's below 10 gets 50,000 units weekly. And that's continued even beyond hospitalization. They're discharged on this for 6 weeks, and they're asked to get a repeat level. And we know that vitamin D helps to prime the T cell aspect of our immune system, which is considered to be important in the body's response to the presence of the virus. So I think it's important that maybe something that others could also decide to do, screen all COVID patients for vitamin D deficiency and see if you also pick up this occurrence that I've observed, which is that the more deficient they are, the more likely they are to have severe COVID.
Wonderful. I'm so glad you picked that up. Thank you. We're out of time. We never get all the questions in. Thank you, doctors, all of you. You were terrific. Wonderful stuff. Bye-bye.
Thank you.
Thank you.
Thank you.